topic that's near and dear to my heart. I am a former medical interpreter and written Spanish translator that was born from growing up with a lot of families spoke a language other than English in their home and then back in country, Kansas. And so following all of that, it's now my academic pursuit to improve language equity within ED and within clinical trials. I am an associate professor of emergency medicine at SAEM, and I work clinically in so by the end of this, you will all be able to understand and describe the current state of inclusion with respect to language in clinical trials, and that's for research studies here in the United States. Reflect on the balance between patient autonomy and ensuring really true and appropriate and informed consent while trying to be as inclusive as possible, and then describe some best practices for inclusion of patients with a preferred language other than English in clinical trials. And then we five can collaborate on ways to be inclusive. So I think if you took the time to come, these are things that you already know, but a really significant portion of our population identifies as having a preferred language other than English or speaks a language other than English in the home. And almost a fourth of our population, maybe almost any other, gender, race, ethnicity that were to make up a significant portion of our population would be otherwise noted and included for special accommodation within clinical research, but you will soon can find that's not the case. I have to come up here for my notes for this slide. So this was a study looking at the inclusion of patients who have a preferred language other than English or English fluency requirements, meaning that within their IRB or within their research protocol, they specified that you had to have proficiency in English to be included. And surprisingly, this number is actually going up over time. Before 2000, only 1.7% of clinical trials required English proficiency, and after 2010, that was 9%. I think before that, people just didn't address it at all, and now there's a balance between being inclusive or just saying in order to be included, you have to have English proficiency. If you break this out within industry-supported trials, they have a very low rate of English fluency requirement, only 1.8%, but within behavioral health trials, it's actually very high. It's almost 30%, which, again, because it's a behavioral health trial, I think the intent is to communicate well with the participants, but it certainly leaves out a significant chunk of people. Within the United States, the Northeast has the highest English fluency requirement at 10%, and trials that open in more than one region have the lowest English fluency requirement at 3%. Not surprisingly, towns where I grew up in Western Kansas with a large Hispanic population are much less likely to have English fluency requirements. Zip codes with more residents who identify as Black or African American or Asian or have high poverty rates actually tend to have higher English fluency requirements. So we can see that geographically, if it's a place with high Hispanic identifying population, there will actually be, there's Mike, I know him too. If you can find a seat, just try. But zip codes that likely have a higher population of patients who identify as having a preferred language other than English are actually more likely to have English proficiency requirement for the clinical trials. So this is the current state. Clinical trials This is any interventional study in the United States with at least one site in the United States registered at clinicaltrials.gov, and this was just for 2019 and 2020. They took all of the clinical trials, used a computer program to search for any evidence of an English or Spanish language requirement, and if the computer couldn't find it, then they just did a hand search. So there were 14,367 clinical trials registered in the time period. Almost 20% required the ability to read, speak, or understand English, and that was statistically significant between 18 and 20%. And only 2.7% specifically mentioned accommodation for translation or interpretation to a language other than English. And so you can see if you break it out, overall it was almost 20% required proficiency, under 3% made accommodations. And then if you look at industry-sponsored, 5% require English proficiency and less than 1% listed any kind of accommodation for other languages. And then it's somewhere in the middle there for federally funded clinical trials. So I think it's safe to say that patients who have a preferred language other than English are underrepresented in clinical trials and clinical research. And I hope this comes from a really good place. This gets back to the Belmont report and the common rule and trying to weigh the autonomy of patients to make a good, clear, informed consent free of coercion and justice, where you have equitable selection of research participants, but you also want to have equal distribution of the benefits of participation in research across groups. And so I think this comes from worries about autonomy for patients who have a preferred language other than English, and they would be considered, in many cases, a protected group, so they would be afforded broader protections under the common rule than a non-vulnerable population, because this also not only represents a language barrier, but often a cultural barrier with the experience of Western medicine. And concerns for autonomy seem to be motivating an institution or institutions to have broader protections as a patient group. However, when you think about justice and being able to then benefit from not only participating in the research, but also benefiting from the applicability of the research to your patient group at the conclusion of a trial, I think we need to reconsider the benefits that could be afforded to this patient population by inclusion in research. And to be honest, I'm just hoping people will put it in just study it, right? Race, ethnicity, language, and just include it every time as part of your demographic information to just begin to understand who are we including and how are they benefiting from this. And there are lots of reasons for this. The first is just a basic scientific imperative. If you want to have diversity in research and generalizability of your findings, then you have to have diverse inclusion criteria for your studies. And there's a pretty clear legal imperative. This started with the Civil Rights Act in 1964. In 1994, it took 30 years, the NIH made guidelines for inclusion of women and minorities in clinical trials, and there are some executive orders from the early 2000s with President Clinton that all federal agencies would remove language barriers for people who have preferred languages other than English. So it's a pretty clear legal imperative, but we'll talk a little bit in the barriers. The imperative is there, but the mechanism to address it is likely not always there. And I think just an ethical imperative to include minority groups in clinical trials so that they can benefit from being included and then benefit from the fruits of the research. So I feel like I'm missing, okay. The best practices are basically including language in every step of your research. So when you're in the formulation phase and doing a literature review and looking at background as you formulate the idea for a study, is you really want to look at the target population and the population you intend to study at the outset and find out what languages are represented and what percentages of the patients prefer a language other than English in the target population that you intend to study, such that when you are in the planning phase and budgeting for your trial, you can include accommodations for other languages. That includes written translation, transcreation, interpreters for consent, patient navigators who have a better cultural understanding, not just language interpreters, but true patient navigators who have a better cultural understanding of the experience of medicine and the experience of research within your group. And if you budget this in, then you can move forward and have all of these robust methods in place in your trial once you hit the ground. The other best practice is community engagement, really leveraging clinicians who are embedded in populations who have a preferred language other than English, establishing relations with community groups, medical and non-medical, who serve these groups, and identifying patient navigators or access champions within the community who can be a bridge between our establishment and the community that we're serving. One thing that we found at Denver Health, at least with our COVID clinical trials, and this is yet to be fully fleshed out and researched, coming soon, but when one of the PIs had proficiency in a language other than English, the likelihood that they enrolled more people who also had a preferred language other than English was very high. So that gets down to not only accommodating this in our research planning, but also really building up and mentoring and bringing up physicians and researchers and scientists who speak other languages, right? There's also some toolkits. The EDIC Backpack and Class Act are available online, and they're really well done and extensive best practice kits for being inclusive with your clinical trials, and that's with respect to language, women, minorities, everything. I believe a slide of mine was skipped here. It was X'd out because we have to talk about barriers. It's like a hidden slide, and I'm not sure. If it will show up here. Here, did we go through this? No, I don't know. For some reason, it skipped it. So I was thinking it was being skipped when I was going through, because I was like, I'm missing a slide. But we'll just go through this really quickly. There are a lot of barriers to inclusion. One is variable IRB policies, and that's across institutions, states, federally. At CU, if we enroll more than 3 patients who speak a language other than English, then we have to have the short form translated into their primary language. And if you plan for this and budget for it, it's not usually a problem. But if you aren't planning for it, that can become cost prohibitive pretty quickly, because if we enroll more than, we would certainly be enrolling, Spanish, probably Arabic, probably Russian, and so if you plan on it ahead of time, it's less of an issue, but you have to know what the IRB, your local IRB accommodations are for language, if they have any, and anticipate that and plan for it. And again, while there is a legal mandate for inclusivity, there's really minimal federal guidance as to how to achieve that. And then even if we are really thoughtful and thinking ahead and translating and transcreating documents, meaning you don't just translate the words, but you translate the full meaning, and having interpreters and patient navigators and cultural navigators, it's still a language and cultural barrier, and that can't really be brought down, but we want to mitigate it as much as possible. And then there's just lack of knowledge among research staff as to how to address all of these things. Not every scientist embraces this as at the forefront of their IRB. So We are just about right on time. We have enough for maybe one breakout, but I don't know if anybody here has successfully enrolled patients who have a preferred language other than English, or has found other things to be helpful to share with the group. Or if you don't want to share, we don't have to share.
We haven't started recruitment yet. I'm Shulay Mas from University of Rochester. I'm part of a bigger group, and we have R01 that's about to get started. We translated a lot of things to Spanish, like all the intervention and all the guidelines and everything to Spanish. So we have that, but we haven't started recruitment yet. We're just kind of rolling practices at this point.
That's great. Congratulations. What are you studying?
Well, I work with Supriya Mohili from University of Rochester's Medical Center. My work focuses on improving patient care and language and serving for older adults with advanced cancer. Yeah.
Wow.
Yeah.
Yeah, but I imagine there are other positions.
Yeah. Minoritized groups.
Yeah, sure.
I'm actually trying to develop a customizable care plan for them so they receive more of a full concordant care and language and serving.
And like I said, I think that's one of the things that is really helpful to offset. And then again, you can see that we can look at it as a different time. It's going to be access to study now. Speaking another language, then you might start to see it. Spanish is
Pretty common, yeah.
but it's
So a lot of the measures are standardized in Spanish already.
yeah.
We talked about trials in this, but I'm curious your thoughts on a lot of human research, like epidemiologic research, and home studies, they're doing chart review. What is your opinion of how well we record people's preferred language when we have them, for example? Like, is it even worth trying to analyze? I feel like sometimes it's inaccurate.
It depends on the institution. I mean, Denver Health in the last 3 years, Denver Health has a whole new campaign to improve documentation of race, ethnicity, and language. So it's like a hard stop in the chart and registered now. So it's supposed to be there for everyone. The accuracy of what people self-report and what's true is always hard. But I think the Denver Health is getting a lot better. But it depends on. Denver Health has a big push for that, but the university and St. Joe's and PSL, if you're doing truly operations. Anyway, I just started with this.
Yeah.
The data is there.
Right.
So it occurs to me that whether somebody is proficient in English, whether they primarily speak English at home, and whether their preferred language is English, are really three completely different questions. Which one's I was going to say the right question. Which one's the best? What's the right measure? And I'll just go to is there any kind of validated verbiage for eliciting that? Because I'm assuming the way you ask that question might influence the answer.
Yeah. I humbly would say it's the language we prefer. Because that's the most patient-centered. Just choose. You get to choose. But how that came about and whether or not it was validated, I don't know. I don't know.
I think top literacy is really important. Like even if they you can translate the measures to a different language, or you can ask other questions. If they don't have top literacy, it's going to be still challenging having them answer it properly. Or if you understand the question, the nature of the question that you're trying to.
Yeah, it's not just inclusivity and concept topics, it's good data collection.
Absolutely. Yeah.
I'm just trying to stir the pot and think of it and talk about it.
Do you know, I'm clearly very interested in this, are there countries, and I don't know, I'm thinking like Europe, or there are multi-lingual countries, are Are there places that are doing this well?
My impression, and because it's a similar, the language dominance, there's always a dominant language in the country. And there's studies around this in Australia and Europe, even in emergency departments and how people with language other than the dominant language access the healthcare system. And I don't, I mean, we could probably go down a rabbit hole of like colonialism and language dominance, but every culture has that language, and if you're although I would anecdotally think more people in other countries.
Yes.
As a tribal language.
It's very normal to speak true English.
Yeah.
Where you grew up.
I have my sister-in-law, she lives in Belgium, they teach 6, 7 languages right from the get-go.
Yes. Yeah, yeah, and our friends in Germany. One dad, that's Flemish to them, German to them, and they go to English school and French. And they just, but even